Today's lecture is on thoracic trauma imaging. So let's start with it. So in this lecture, both thoracic cavity and chest, these terms will be used interchangeably. So during a chest trauma, it is very important to perform both the imaging and the physical exam. Physical exam to gauge the site of the damage, to examine how much the damage has taken place, and then the imaging to measure how much that extent is, which organs are involved, the severity of it, the angle of it, and the projection of it. During the chest trauma, the most common damage that we see is a rib fracture. And for rib fractures, what we do is simple chest x-rays, but in a series. And also we take into account the site of the fracture. So for the anterior posterior wall, we do an AP projection, because in an AP projection, the radiogram is behind the patient. For the anterior chest wall, we do a PA projection, because again, the radiogram is in front of the patient. And during the complicated or multiple fractures, we perform multiple PA, AP, oblique, and sometimes decubitus projections. And all of these are done in series, in multiple time frames. The reason being, during the chest trauma, the damage is always developing. The hemorrhage, the extent of the damage, the tissue, it's always developing. So a series of chest x-rays is done. Also, during the imaging, auscultation and percussion during the physical exam must also be done, because it can help us initially, because during the trauma, time is always of the essence. So it tells us where the damage is, if there's pneumothorax, if there's some kind of complication, there's some kind of tension pneumothorax or any other complication can be examined firsthand through physical. The second most damaged part of the chest wall during trauma is the sternum. For sternum, again, we do a plain chest x-ray. But if during the physical exam, the sternum seems okay, but the patient is still complaining of pain, or there's a suspicion of fracture or a hairline fracture, then we perform an unenhanced CT scan. An axial CT scan will definitely tell us if there's any damage to sternum or not. It has displaced or any kind of other damage. The next thing to damage during a chest trauma is the lower chest and the abdomen. Now, during chest trauma, ribs, and usually the lower ribs, not only puncture the viscera or the organs in the chest cavity, but also in the abdomen. Usually the abdomen is punctured by the floatings or the lower ribs. And for these, the first thing is to do a CT scan, because the CT scan will tell us if the rib has punctured any viscera, where it is punctured, is there any bleeding. Simple chest x-ray will not tell us a complete picture. CT scan is usually preferred during a complicated chest trauma where the upper abdomen is also involved. Next, we also perform an ultrasound, because during ultrasound we can actually see if there is an active bleed, the site of puncture, the diameter of puncture, all of these things can be gauged out and examined in real time during the ultrasound and the Doppler ultrasound. So, if the chest trauma also involves the upper abdomen, both the CT scan and ultrasound, especially the Doppler one, is used. Next, for the chest wall injury. Sometimes during trauma, we do not find any injury. So, for these special kind of cases, we perform a radionuclide bone scan. And that bone scan sometimes tells us that this trauma might not be due to some blunt force. It could be due to some malignancy or some other thing. Next, for the rib fractures. Now, rib fractures are usually seen in the PA view, and what we look for is called cortical discontinuation. Here in this chest x-ray, you can see this rib, the cortical, this line here, the cortex of the rib is clean and continuous, but here it is not. This slight bump in it. So it does not indicate any fracture at this point, but it says that something is wrong here. But the lateral view of the same patient tells us a very different picture, that it is not a simple bump or a congenital problem. It is actually a superimposed rib fracture. So that's why during rib fractures, both series of x-rays are done, because one projection will not tell the whole story. Next, for the rib fractures, sometimes rib fractures have a very localized effect, and this localized effect or localized puncture will produce a localized bleeding or hemorrhage. This here is an example of hemothorax, but this hemothorax is localized. It is just focused in this part, and in this part the pleura is visible and thickened. So this area, because of the pleural thickening and because of its focal ability, we can tell that it's a hemothorax, or it could be a pneumothorax, but that is a topic for the next. Sometimes there's not just one rib that fractures. In complicated accidents, multiple rib fractures happen, and these multiple rib fractures puncture viscera at multiple points. For these kind of fractures, the primary thing that happens is a pneumothorax, because when the rib fractures the lung, air escapes into the chest cavity, and that escaped air into the chest cavity produces the pneumothorax. Here you can see there are multiple rib fractures. There are a lot of them, 1, 2, 3, 4. 4 ribs are fractures, and they are puncturing the left lung. And here, this area, this is the subcutaneous emphysema. The air is leaking out into the subcutaneous area. So we can tell by this that this fracture is complicated and it is puncturing the viscera or lung in this example by just looking at this subcutaneous emphysema. Next, we have the complications. Now, usually there are 3 complications whenever a rib fracture happens. The first one is a pleural contusion, a plain simple laceration. It could be a hemothorax where blood accumulates in the thoracic cavity, or it could be a pneumothorax, where the air accumulates in the thoracic cavity. Now, in this MRI, you can see that this rib is fractured. You can tell it's fractured because both the cortex is discontinuous and it is jumbled up and cut in the middle portion. And this rib is puncturing the lung at this area, and the whole of the chest cavity at this left area is filling with blood. Now, if it was air, it would have a black consistency, but this consistency explains that it is actually blood and it is active. We can tell it is active because this area here is the primary bleeder and this is the accumulation or the pooling of the blood. Next complication is, as I explained, is the pneumothorax or the presence of air in the thoracic cavity. Now, whenever pneumothorax happens, lung collapses. It shrinks and increases its density. And on the chest x-ray, we can find it out by actually this measuring the visceral pleura. Now this white line here actually represents the lung, and this whole area is actually air, which is due to the rib fracture is escaping into the thoracic cavity, into the pleural cavity, and is separating both the pleura, and the lung is collapsing. So this complication where the air enters the thoracic cavity between both the visceral pleura and the chest wall is called pneumothorax, and it is a very dangerous condition and must be corrected immediately. There are a lot of remedies, there are a lot of treatments, but they will be discussed afterwards. Here is again what I said, the visceral pleural line. Next is the dyspnea. Now, dyspnea means shortness of breath or difficulty in breathing. It means that you are short of breath. What usually happens during dyspnea or the difficulty in breathing is the oxygen saturation lowers. Why? Because there's not much oxygen going inside the lungs, and the rate of respiration increases. Now, New York Heart Association describes dyspnea into 4 categories: NYHA 1, 2, 3, and 4. NYHA 1 is where there is no dyspnea present. 2, when the symptoms are mild, when there is no exertion involved, and they resolved on rest. NYHA 3 is when the symptoms are moderate, and they are usually associated with exertion, but the patient relaxes on rest. NYHA 4 is when the symptoms or dyspnea is severe. It is not only exertional, but it is also continence, and even on the rest, patient suffers from dyspnea. Now, for during dyspnea, the type of modalities that we use are the radiographs, the plain chest x-rays. Now, we do both the AP, PA, and the lateral view if the patient is ambulatory, if the patient can walk, if the patient can stand up, then we prefer to do a PA or AP view or lateral view depending upon the trauma. Or if the patient is NYHA 4, unable to stand, bedridden, then we perform a portable AP, projection radiograph. Now, if normal chest x-rays do not give us the root cause of the dyspnea for the patient, then we can always move to the next modality, that is the CT scan. And for dyspnea, CT scan is usually done in two ways, either in the HRCT way or in the CTPA way. HRCT stands for high resolution computed tomography. Now, why we need high resolution for the chest cavity? Because chest cavity composed of not only heart and ribs and muscles, but also the lungs. And lungs are very delicate, very intricate tissue. And because of their intricacy, the CT scan must have very good sharpness, must have very good detail. So all of this sharpness and detail can be achieved with a high resolution CT scan. And all the abnormalities and the differences in the parenchyma of the lung can be detected very, very easily. Now, if the problem of the dyspnea is due to, if the doctor suspects due to the vasculature in the lungs, then we can always perform a CTPA or computed tomography pulmonary angiogram. Now, pulmonary angiogram is where we inject a dye and then observe through a series of CT scan images taken with a multi-detector CT that how the vessels are responding to the injection of the dye. Now, this injection of the dye moves through the pulmonary vasculature, and whenever it finds a blockage, it stops because the blood is not flowing. And those images can be used to find out any problem. Either it's a pulmonary embolism, it's some kind of occlusion, stenosis, dissection, or ulceration, or some kind of atherosclerotic plaque. All of these problems in the vasculature can be found out by CTPA. Now, if the dyspnea is of cardiac origin, then we do what is called a cardiac workup. Now, we do a battery of tests such as the ECG, electrocardiograph, the echocardiogram, that is the ultrasound of the heart, or we can perform a radionuclide study such as thallium scan, a CT, a cardiac CT, or MRI. But usually what we perform is called a VQ scan in most hospitals, and this is what you will encounter mostly. A VQ scan is a ventilation perfusion scan where we actually examine how much the lungs are taking the oxygen and air in and how much of it is traveling towards the whole of the body, how much the perfusion of the distal or the peripheral tissue is taking place. Now, this scan gives us a very good idea if the dyspnea is of the pulmonary origin or of cardiac origin. Next, one of the leading causes of dyspnea is bacterial pneumonia. And during bacterial pneumonia, what we usually find is consolidation. Consolidation in lungs is replacement of air. Now, that replacement can be by any fluid, water, and fluid can be both serous or mucoid, or it can be due to a mass. So, in bacterial pneumonia, what we find is a segmental consolidation. We can say it's a segmental consolidation because of this convexity, which signifies the minor fissure, and above it is the consolidation, where the fluid is accumulating and is replacing the lung parenchyma. Now, whenever there's dyspnea, and dyspnea is due to the consolidation in lung parenchyma, we get signs. One of the signs that we do get is called an air bronchogram sign. Now, the air bronchogram sign is the appearance of bronchioles inside the consolidation. Now, this is the lung opacification or consolidation. But even through this consolidation, we can trace out the pathway of the bronchiole. This is because the bronchiole is thickened because of the inflammation, because of the pneumonia, because of the bacterial infection. Now, if the pneumonia is not of bacterial origin but of viral origin, usually we do not get an air bronchogram sign, but what we do get is called peribronchial cuffing. Now, in viral pneumonia, the thickening of bronchioles is not extensive, but it is still enough to cause this ring-like structure to appear, which is the lumen of the bronchiole. We also get these parallel lines, which are called the tram tracks, which are actually due to the thickened bronchi, which lie closely together. Trams are actually railways, but instead of working on the roads, on the rails, they work on the grooves on the road. So just like the grooves on the road, we see these tracks, the parallel bronchi on the chest X-ray lung field. Next, one of the cause of dyspnea in children is a croup. A croup is defined as an inflammation of vocal cords. Now, it is not only common in children, but it is also very common in singers and teachers. A child with croup with an inflamed vocal cord will have what is called a steeple sign. A steeple sign will replace the normal scarish looking vocal cord area inside the trachea with conical shapes. And these conical shapes or steeples is what is called a steeple sign. And this is very pathognomic of a croup in child. Now, croup in a child must always be distinguished with an acute epiglottitis because they are both very similar. But we only get the steeple sign in croup, and in the acute epiglottitis, we get a thickened epiglottis. This is a lateral chest X-ray. This is the trachea, the upper trachea, and this is the epiglottis. Now, this blue margin is what a normal epiglottis should be, but in acute epiglottitis, because of the inflammation, it is swollen, it is thickened. And this is what we see on this chest X-ray. Now, dyspnea is not a disease, it's not a condition, it is a symptom of a much larger condition. So, in order to find out the root cause of dyspnea, to confirm the diagnosis, CT scan is very readily used. And one of the most common conditions in which the CT scan is used to confirm the diagnosis, in which dyspnea is part of the symptoms, is the interstitial pulmonary disease. Now, this axial CT scan is having a very peculiar picture. These two instances here are having very different parenchymal structure to the other parts, and this is what we call ground glass opacity. Now, this ground glass opacity is like there's a mixture of different structures that is happening here, because an interstitial pulmonary disease, the interstitium or the collagen or the connective tissue is replaced, Now this replacement can be reticular, like thread-like. It can be nodular, like micronodular, tiny nodules take up the place, or it can be, or in the most cases, reticulonodular. This reticulonodular is what gives us this ground glass opacity, which is very characteristic of interstitial lung disease. Another cause of dyspnea that is very common and can be examined on a CT scan is an advanced lung fibrosis. Now, this fibrosis, usually on an axial CT scan, gives us a special appearance which we call the honeycombing. Now, this honeycombing actually turns the lung parenchyma into tiny cells which are divided by septa, and this mimics the appearance of the honeycombs which the honeybees make. So whenever we get this picture, it is again very descriptive of an advanced lung fibrosis, which can be due to asbestosis, it can be due to silicosis, or any of the pneumoconiosis. Another cause of dyspnea is what we call bronchiectasis. Bronchiectasis means that the lumen of the bronchioles enlarges. This can be examined and observed in the CT scan. In this CT scan, we can easily tell that the lumen of the bronchioles is enlarged. It is not normal. So, if we get this picture, we can be we can easily say that bronchiectasis is present. Another cause of dyspnea, a very common cause of dyspnea that can be diagnosed on CT scan, is emphysema. Emphysema means that air is present inside a tissue where it shouldn't be present. We already saw an example where the air escaped into the subcutaneous tissue, which caused the subcutaneous emphysema. But when air escapes into the lung, where it shouldn't be, outside the alveoli, when the alveoli starts to destroy, when they are replaced with structure, replaced with air, is what we called emphysema. And usually emphysema starts at the center. So when it starts at the center, we call it centrilobar emphysema. And this emphysema usually spreads, and it spreads out towards the lung, and it can even spread to the whole lung, and this can give rise to a panlobar emphysema. Here you can see that emphysema, the presence of air, has encroached almost whole of the lung, and this picture is very typical and very common of heavy smokers, where a focus spreads into the whole of the lung. So more the emphysema, more the destruction. Now, another type of emphysema is what we call paraseptal emphysema. Now, paraseptal emphysema is a special type where it can be due to subpleural bulla. It can be due to paraseptal, where there are multiple emphysema, multiple air pockets inside the lung, and this is called paraseptal emphysema. And this emphysema is not only encroaching the parenchyma of the lungs, it is actually destroying it, it is replacing it. So it is a very dangerous and very complicated picture. Now, if a patient along with dyspnea is also having tachypnea, that is increased respiratory rate, is also have some other indicators such as increased heart rate, one can also be sure that the patient might suffer from a pulmonary embolism. And a pulmonary embolism is a very, very fatal condition. And it is usually diagnosed on a CT-PA or a computer tomography pulmonary arteriogram. Here, this is a picture of a CTPA. This is the area of the emboli. This is the pulmonary vein that is blocked by this embolus. Now, pulmonary embolus usually happen due to DVTs or deep vein thrombus in the lower limbs. So whenever we see a pulmonary embolus, three things must always be performed. One is the ultrasound of the veins of the lower limbs to rule out any DVT or deep vein thrombosis. Test of the dimers is performed to check how much the thrombus and the thromboembolic activity has taken place. And third one is to check the place or to check the saturation of the oxygen or any other test which tells us that embolus has lodged into the vasculature of the lung. Next chest trauma is hemoptysis. Hemoptysis is defined as the presence of blood during coughing, and it is a very serious symptom and should not be taken lightly. Now, whenever we see a patient with hemoptysis, the modalities of imaging that we're going to use are simple plain chest x-rays, because usually the most common causes of hemoptysis such as pneumonia can be diagnosed on a simple chest x-ray. Another thing is we can perform a contrast enhanced CT scan. Now, there are three main causes of hemoptysis. One is infection, two is malignancy or tumor, three is an AVM. AVM is an arteriovenous malformation, meaning the arteries and veins at some points have jumbled up together and they are bleeding and they are hemorrhaging. So these three main causes can be diagnosed, can be confirmed through these modalities: the simple chest radiograph, the contrast enhanced CT scan for malignancies, or PET scanning. Now, hemoptysis due to malignancies usually does not give us a right away answer, a primary tumor. We usually get endotracheal tumors which are producing hemoptysis. So in order to diagnose those tumors, we resort to the PET scan. PET scan means positron emission tomography, and in this scan we can find out even the tiniest and the slightest of the tumors, and those endotracheal tumors which are the cause of hemoptysis can be diagnosed on the PET scan if they're not diagnosed on the contrast enhanced CT scan. So for hemoptysis we use these three modalities. Now, like I said, one of the most common cause of hemoptysis is infection, and the most common infection with hemoptysis is pneumonia. And this is a very typical picture of a viral pneumonia. This is what is also called looking inside a barrel. Again, we are seeing peribronchial coughing, which is due to inflamed and thickened bronchioles. We are seeing tram tracks, again due to thickened bronchi, which are lined up together. And this gives us a very typical picture. So whenever you see this picture on a chest x-ray, be sure to give it the differential diagnosis of viral pneumonia. Another cause of hemoptysis is atelectasis. Atelectasis means collapse of lung. Now, atelectasis can be complete. There can be a complete collapse of lung, or it can be segmental or lobar, that some lobe or segment has collapsed. Collapse represents that the size has shrunk and density has increased, and that part or the complete lung has lost its ability to ventilate. And it is a very serious symptom and issue, and it must be corrected readily and quickly. Here is a chest x-ray with a left lower collapse. Now this collapse is actually due to a mass behind the heart, and this mass is encroaching upon the left lung field, and that field of the lung has collapsed onto itself above the diaphragm. So one of the causes of hemoptysis, that is malignancy, can be found out due to atelectasis or a collapsed lung. So if you see hemoptysis with lung collapse, there must be a malignancy or mass which is producing the hemorrhage or the blood. Another cause of hemoptysis, like I said, is pneumonia. Now, bacterial pneumonia is major cause. Previously, I've shown you the picture of viral pneumonia. This is the typical picture of a bacterial advanced pneumonia. The consolidation here is so large that it has covered whole of the lower field. It has produced the silhouette sign, that is the mediastinal margin is lost here. So if you see this kind of picture in pneumonia with a patient with hemoptysis, be sure that it is causing the patient Another cause, like I said, of hemoptysis is malignancy, which usually present as masses on axial CT scans. Now, here is an axial CT scan, and this pulmonary mass on the right lung field is giving mediastinal adenopathy. Now, this mediastinal adenopathy is what is producing the blood, and this blood, along with blood produced by this pulmonary mass, gives rise to the hemoptysis which the patient is suffering from. So any mass in the lung field will produce hemoptysis sign. So what did we learn? We learned about the chest trauma. We learned that chest trauma is always an emergency, and the choice of modality to use during that emergency is not only time critical, but it is vital to the patient care. We learned all the modalities from HRCT to CTPA to contrast enhanced CT scan to plain chest x-ray. All of these modalities play a vital role in the chest trauma. We learned which structure get most damaged during the chest trauma, from rib fractures to the sternal fractures to the contusions to hemothorax to pneumothorax to all the complications that can occur due to a rib fracture. We also learned about dyspnea. We learned what type of dyspneas are there, which dyspnea is present in which condition, and how to diagnose those conditions with patients of dyspnea based on either plain chest x-rays or CT scan or any other kind of imaging. So we learned all those steps for dyspnea, and we learned all the diseases which can easily be diagnosed on CT scan or MRI or plain X-ray. Then at the end we learned a little about hemoptysis, that is the coughing of blood. We learned how it happens, where it happens, and what are the usual suspects for hemoptysis. One of the usual suspect is the infection, the inflammation, then we have the malignancies, and we even learned about the AVMs, which are usually the cause of AVM hemoptysis. So that was the lecture, thoracic trauma. Thank you for watching sqadia.com.